Hello and welcome to this session on severe hypertension and eclampsia. So in terms of our session objectives today, we're going to give you updates from the 2019 NICE guidance on hypertension in pregnancy, updates from Embrace UK reports and recommendations, a recap on diagnosis and management of hypertensive disorders in pregnancy, a recap of emergency management of severe hypertension, severe preeclampsia and eclampsia, and human factors considerations as well. So what is the scope of the problem? So 1 in 10 pregnancies in the UK will be complicated by hypertension, and up to 6% of all pregnancies will be affected by preeclampsia, so it is a significant problem still. Death rates are going down, so now it's the 6th leading direct cause of maternal deaths, but they do happen, and so we need to be prepared for managing women in these circumstances. In terms of the leading causes of death relating to preeclampsia, intracranial hemorrhage is the leading one, and that's usually secondary to inadequate control of hypertension. And hepatic necrosis and HELLP syndrome are the second. In terms of learning points from Embrace, so in the 2019 report, covering deaths between 2015 and 17, 6 women died from hypertensive disorders, and in all cases improvements in care may or would have made an improvement or a difference in the outcome. And they've highlighted the importance of commencing aspirin from 12 weeks for eligible women. And these leading causes of death are further confirmed in the 2020 Embrace report, with intracranial hemorrhage secondary to uncontrolled hypertension and acute fatty liver pregnancy being leading causes of death. And so severe hypertension with blood pressure above 160 to 110 is an emergency in both pregnant and postnatal women, because most deaths occurred in the postnatal period. So in terms of indications for aspirin from 12 weeks, so women need to have one high risk factor of either hypertensive disorders in a previous pregnancy, chronic kidney disease, autoimmune disease, type 1 or type 2 diabetes or chronic hypertension, or 2 or more moderate risk factors, which are listed on the slide in front of you. So in terms of a recap of hypertensive disorders, so the definitions of essential or chronic hypertension is hypertension diagnosed before pregnancy or before 20 weeks, and gestational hypertension is a new diagnosis of hypertension in pregnancy after 20 weeks. And for both, women have no proteinuria, and they may be classified as mild or moderate to moderate with blood pressure less than 150 systolic over 109 diastolic, or severe if blood pressure is above this. So in terms of the definitions of preeclampsia, so that's new hypertension over 20 weeks with significant proteinuria, either 1+ or more of protein on a urine dip or a PCR above 30. And severe preeclampsia is the above with severe hypertension and plus or minus symptoms such as headache, epigastric pain, significant edema, and visual disturbance. And women may have biochemical or hematological impairment. And eclampsia is a convulsive condition associated with severe preeclampsia. So PLGF is a new test that can be done to quantify the severity of preeclampsia and can be used to help predict how we should manage these women and whether they should be managed as an inpatient or outpatient. PLGF is a protein involved in placental angiogenesis, and in PET levels can be abnormally low. It can be detected by a blood test, and as I said, it can be used to aid clinical judgment in women who are suspected to have PET. It's used between 20 weeks and 34 plus 6 weeks gestation, and it's being rolled out across NHS England. So in terms of the signs and symptoms of preeclampsia, so frontal headache, visual disturbance, including blurring or flashing, vomiting and epigastric pain, sudden severe swelling or edema of the face, hands and feet, reduced fetal movements and abdominal pain, and vaginal bleeding if there is a placental abruption, which is a complication. Other maternal complications include intracranial hemorrhage, placental abruption as mentioned with DIC, eclampsia, HELLP syndrome, which is a condition characterised by hemolysis, elevated liver enzymes and low platelets. And eclampsia severe preeclampsia can cause renal failure, pulmonary edema, and in severe cases even acute respiratory arrest. In terms of intracranial hemorrhage, so it's still thankfully rare in pregnancy. However, for every 100 women who have had a hemorrhage, 96% of them will have had a high blood pressure with a systolic above 160. So therefore, blood pressure above 160 systolic in pregnant women or postnatal women is an emergency and should prompt midwives to rapidly escalate the patient to a doctor and doctors to rapidly initiate treatment. Acute fatty liver of pregnancy is a potential fatal complication in the third trimester, and it can coincide or can be confused with severe preeclampsia or HELLP syndrome. It causes hypertension and proteinuria, the same as PET, nausea, vomiting, abdominal pain and headache, and patients can get a rapid development of liver failure, jaundice, ascites, DIC, encephalopathy and hypoglycemia, and they can progress to renal failure and multi-organ failure. So if it's suspected, early involvement of senior obstetricians, hepatology, gastroenterology and ICU is needed. Here's a case history from Embrace UK 2019. A woman with risk factors for preeclampsia presented at term with an abnormal fetal heart trace. She had an emergency caesarean birth. Postnatally, she had significantly abnormal renal, liver and clotting function, but there was no direct consultant obstetric involvement, and the severity of her illness was not recognised until very late. There were differing opinions about transfer to an intensive care unit, and despite multi-organ problems, she remained in the obstetric HDU. She continued to deteriorate with markedly abnormal liver function, but at no point was a gastroenterology or hepatology opinion sought, and unfortunately she eventually died from her liver failure several days after giving birth. So recommendations based on this case from Embrace are that women with multi-organ dysfunction need consultant involvement, and there should be early consideration regarding optimal setting for their care and whether transfer to a local or specialist ICU is warranted. So hypertensive disorders don't just affect mothers, they also affect babies. And in terms of fetal complications with preeclampsia, they include intrauterine growth restriction, oligohydramnios, hypoxia from placental insufficiency, placental abruption and preterm birth. So in terms of additional resources, so the most recent NICE guidance on hypertension in pregnancy is available online, released in June 2019, and King's College London have developed a decision aid infographic on the management of severe hypertension in pregnancy. So in terms of managing severe gestational hypertension when blood pressure is above 160/110, it's important to treat this. So admit women and treat until blood pressure is stabilised. Follow the NICE guidance and your severe hypertension algorithm. And once you've initiated treatment, the target should be for blood pressure of 135/85 or less. And it's important to monitor women, so repeat blood pressures every 15 to 30 minutes if their blood pressure is above 160/110 until it is below this. Do a daily urine dip for protein when they're admitted, and obviously if that has any protein, then perform a UPCR. Do weekly bloods, including a full blood count, USNEs and LFTs, and perform growth scans at diagnosis and then every 2 weeks to look for growth restriction. And a CTG should be performed at diagnosis. In terms of other additional tests, so you can carry out a PLGF based testing on one occasion if there's suspicion of preeclampsia. This is the prompt treatment algorithm for severe hypertension, and it's based on the NICE 2019 guidance, looking at your choice of antihypertensives and how often you should give them to lower the blood pressure when it's above 160/110. In terms of your choice of antihypertensive, so labetalol is the first-line treatment for management of hypertensive disorders in pregnancy. However, it's less effective in Afro-Caribbean women and should be avoided in women with asthma. And in these circumstances, or if the hypertension is resistant to labetalol therapy, nifedipine should be used. So the release profile of nifedipine is not specified in NICE guidance, and decisions should be based on requirements for urgent treatment of severe hypertension due to the increased risk of stroke. So moderate release nifedipine preparations are preferable. However, if systolic blood pressure is above 160 and you require rapid treatment, immediate release nifedipine capsules can be considered. However, beware of dropping the blood pressure rapidly, as this can lead to placental perfusion issues, and as well with women who have renal disease, then blood pressure drops can be harmful as well. So now I'm going to move on to managing severe preeclampsia. So this is our management algorithm for severe preeclampsia. So it's important to stabilise your woman. So firstly, controlling blood pressure, secondly, preventing seizures, and thirdly, escalating and involving senior obstetrician and anaesthetist input. So in terms of preventing seizures, so consider magnesium sulfate if birth is planned within the next 24 hours and one or more of these features of severe PET are present. Ongoing or recurrent severe headaches, visual disturbances, nausea and vomiting, epigastric pain, oliguria and severe hypertension, or progressive deterioration of blood tests. Here is the magnesium sulfate emergency regimen, and you should have one in your unit. Make sure you familiarise yourself with it and ask for it to be put into your eclampsia emergency box if it isn't already. So in terms of monitoring, so strict fluid balance is really important in eclampsia and preeclampsia, and excessive fluid input can lead to worsening hypertension, pulmonary and cerebral edema. So make sure you're looking at the input and restricting it to 1 milligram per kilogram per hour or 80 mils per hour, unless there's ongoing fluid losses such as a hemorrhage, and make sure you're keeping an eye on hourly urine output measurements, and these should be above 100 mils over 4 hours. If oral intake is adequate, IV fluid replacement is not necessary, and don't preload with IV fluids if you need an epidural. So magnesium sulfate management. So magnesium sulfate should be continued for 24 hours from starting, or if birth occurs, for 24 hours after birth, as preeclampsia or eclampsia can deteriorate after delivery. It's important to monitor urine output hourly, deep tendon reflexes and respiratory rate, and you're looking out for signs of toxicity. So toxicity can cause loss of deep tendon reflexes, respiratory depression, and in severe cases respiratory arrest and cardiac arrest. Magnesium sulfate is excreted by the kidneys, so that's why it's really important to monitor the urine output. Management of magnesium sulfate toxicity includes stopping the infusion and administering calcium gluconate or chloride. So women should be monitored in an HDU setting, ideally on labour ward. A maternal critical care chart should be used, and observations every 15 to 30 minutes until the blood pressure is stabilised, and then at least hourly should be taken. Bloods, including full blood count, usinase, LFTs, clotting, group and save and venous blood gas are useful in monitoring and management. A strict fluid balance, as we've mentioned, and women should be reviewed at least every 4 hours by a senior obstetrician. If you're not delivering and the woman is on magnesium sulfate, she should have a continuous CTG. Plan for labour or birth, so it's important to stabilise blood pressure before administering anaesthesia. Syntocinon and carbetocin, not syntmetrin or ergometrin for the third stage of labour should be given, as syntmetrin and ergometrin can increase the blood pressure. A caesarean section or induction of labour, depending on the severity of the situation and preferences of the woman, should be considered. And second stage does not necessarily need to be shortened unless the blood pressure is not responsive to treatment. Postnatally, it's important to avoid non-steroidal medications until you're sure that the usinase are normal. And you need to plan venous thromboprophylaxis, which will depend on the platelet count. So it's important to keep doing regular bloods to monitor these things. So now we're going to move on to eclampsia. And each unit should have an emergency box for managing eclampsia. And so make sure that you know where your emergency box is located and what is in it. So if a woman is having an eclamptic seizure, it's important to call for help, either via 2222 or the emergency bell, declare the emergency to the oncoming team with an S-bar, get the emergency box, do an ABC, airway breathing circulation, administer high flow oxygen, lie the mother in left lateral, obtain IV access and take bloods, and commence magnesium sulfate, which is the same as the regimen for preeclampsia. Electronic fetal monitoring should be used, however, it's important to stabilise the mother first before thinking about the baby. This is our immediate management of eclampsia algorithm. So moving on to postnatal care. So this is another case from Embrace 2019. A woman had raised blood pressure in labour and was given a single dose of oral therapy. She went home shortly after birth without treatment and had no postnatal checks for her blood pressure, and she had a cerebral hemorrhage at home. So there's a real emphasis in the most recent Embrace reports of postnatal monitoring and having a postnatal monitoring plan. So any woman treated with antihypertensive medication antenatally or intrapartum requires additional postnatal BP checks and to continue antihypertensives until hypertension has fully resolved. Postnatally, if blood pressure does fall below 130/80, then you may need to consider reducing blood pressure medication. So all women should have a care plan outlining who will provide follow-up care once they're discharged from hospital, and there's a recommendation that women have a review by a GP at 2 weeks if they're on antihypertensive treatment, and all women should have a review by a GP at 6 to 8 weeks as they're at increased risk of hypertensive disorders outside of pregnancy. The frequency of blood pressure monitoring should be outlined, as well as thresholds for reducing and stopping treatment, and indications for referral to primary care for blood pressure review should be explained to the woman, as well as self-monitoring for symptoms. So in terms of our key learning points, so it's really important to mind the gap. So blood pressure, medication and urine need to be measured at each antenatal interaction. All women need a clear postnatal care plan if they've had a hypertensive disorder in pregnancy. It's important to seek input from seniors and other specialists in severe preeclampsia or if the woman is deteriorating. And it's important to commence women on aspirin from 12 weeks if they fulfil the risk criteria. The leading cause of death from hypertensive disorders in pregnancy is intracerebral hemorrhage, and a blood pressure above 160/110 is an emergency and requires prompt treatment and escalation. And communication between staff should include exact blood pressure measurements. So not the blood pressure is high, but the blood pressure is 168/102. So further key learning points. Some automated blood pressure monitoring systems underestimate blood pressure in preeclampsia. So if in doubt, do a manual blood pressure. Furthermore, remember to consider VT prophylaxis. So VT is a leading direct cause of death in pregnancy, and hypertensive conditions are a risk factor. However, remember, if the woman has severe preeclampsia or eclampsia or HELLP syndrome, you need to make sure her platelets are not low, below the threshold for low molecular weight heparin. Headache of sufficiency to seek medical attention above 20 weeks is preeclampsia unless proven otherwise. Beware of misdiagnosing migraines in these women, and perform a neurological examination and assessment for neck stiffness in all pregnant women with a new onset headache or headaches with atypical features, particularly focal symptoms. Thank you very much for listening to this talk.